Dr. Das on the stage. Can we try this neuromodulation in trigeminal neuralgia?
Sorry, I have no experience in trying this modality in trigeminal neuralgia. Simply because a cutaneous neuroma is slightly different where the nerve is injured and you have a specific base where to apply the electrical stimulus, whereas in trigeminal neuralgia the whole course of nerve is affected. So I'm not sure whether it will work in that case. But definitely there is no harmful effect of it. The electrical stimulus provided is of very low frequency, 2 Hz only. So we can try it, that's all only I can say.
But it's a new thing and we must explore even more studies on this.
Yeah.
So, any more questions?
I think you must study more on the clavicular fractures, post-operative patients. Many of them do have their iatrogenic injuries there, despite our
Yeah, definitely. The supraclavicular nerve, we had 2 patients in our study as well. So, yeah, in any case of traumatic cutaneous neuromas, we can definitely try it. But trigeminal neuralgia, I'm not yet sure. If you try it, please let me know the results. Thank you.
Dr. Arnav, there is a question for you. You have mentioned in your slide that we can do bicorticular purchase under IITV or something you said. But can you do bicorticular purchase under image intensifier?
So bicorticular purchase is a new thing which some people are doing. The trajectory is different in the lumbar area as well as the thoracic area. So what I said is that it is being used, but it is not recommended by your study. Because we tend to forget that the hold of the screws is in the pedicles. When we are fixing a long bone, then we tend to get the distal cortex so that the hold is better. But it does not apply here.
Yeah, so one comment is that the bicorticular purchase, especially in osteoporotic patient, it is very technically demanding because only 3 mm space is there, so you can just go above that cortex. And that, because of the contour of the vertebra, you cannot make it whether you have achieved it or not. So OARM is very essential for that, otherwise you should not try for that.
Yes, sir. Exactly.
So,
one question from my side to Arnav. The spine is a very interesting topic and I am happy to interact all the speaker with a very good insight. My question is the pedicle screw is the most and primary aspect of fixation of all aspect of spine, right from the cervical spine to sacrum. But the rule for putting the fixation is different in the different segment. So nobody know any tools nowadays which can say 100% accuracy even with the navigation system. In the navigation system, out of 100, 1 fails. Even. So my question is the main thing, what to think about surgery at the time of your operation table. So your thought by your assessing by the X-ray or the CT scan, especially in the area where the zone is very narrow. You have to select those areas. It's a good thing. My question is to how to assess the pedicle size by the X-ray or the CT scan. This one is best.
So pre-op CT can be done to assess the pedicle sizes individual levels. It has been done at many places, the literature is present for that. But the problem was 2. One is the kind of population which gets a spine surgery done. Most of them, not all of them, do not actually agree to get a CT scan pre-operatively because they are already getting an MRI done. That is the first problem. Next, all the radiologists which we contacted for this study to evaluate the post-op CT on those readings, most of them didn't agree. So to get a radiologist who does the CT scan pre-operatively and gives you the individual diameter of each of the pedicles is then again a very difficult task.
Yes. Because we all are in fashion of taking MRI and X-ray, that's it. and nobody can bother to take CT scan. So before going to put any screw, our fashion is to take X-ray and MRI, because we more think about the neurology, not think about the stability part. That's my message.
Thank you everyone, and we are running very late, so I will call upon the session, and may I invite Dr. Arnav for felicitation, and may I request Dr. Subhash Chandra sir to felicitate him. Thank you, Arnav. May I call Dr. Gyan on stage? And I'll request Santosh sir to felicitate him along with all the chairpersons. Thank you, Dr. Gyan. Now may I call upon Dr. Abhishek Kumar Das, and I will request Manoj Chaudhary sir to felicitate him along with other chairpersons. May I call upon Dr. Rajiv Anand sir to felicitate Dr. Santosh sir? Okay, no problem sir. So Dr. Subhash Chandra sir can be felicitated by Dr. Rajiv Anand sir. May I call upon stage Dr. Mahesh sir to felicitate Dr. Rajesh sir?
There were few speakers who we hijacked in the previous session. Dr. Chandrasekhar is here. Sir, kindly sir, anyone be on stage to facilitate. Dr. S. Prakash Das is here. And Dr. Swapnil Pedasi. They have given the lectures in the first half. Kindly be on the stage. You have your monitors left. Sir. Dr. Swapnil. Dr. Chandrasekhar is left. He has left or he has left. Is he here? So we have completed the session, I think. We will continue with the quiz time. The winners it's time to decide, and the top 4 team will come on the stage for the final round. So fingers crossed. No one is losing today because everyone is going to learn something, and it's time to keep improving. I think still today the topper winner of the quiz today will represent Bihar in IOA. In my year, I was the one who represented Bihar, with the blessings of my sir. So who is the winner today? Let's see. Answers are ready? Moderator, sir? Is the answer, who are the winners? List of winners. Can you take over the stage? So I'll leave the stage and take over the stage. The next session will be the Dr. R.R. Ganguly free paper gold medal session after the quiz. Thank you very much.
So we have the qualifiers for the PG quiz round, and we have 4 teams, and 3 teams are tied at 25 marks. So the first team is from JL NMCH Bhagalpur of Rajesh Kumar Singh and Abhishek Kumar. Rajesh and Abhishek, please come forward. Next team is from Paras Hospital, Dr. Neeraj Raj and Pushpender Rathore. The third team is from AIIMS Patna, Mohit Verma and Swam Das. Please come forward. And all these 3 teams are tied at 25 marks each. The next team scored 30 marks, and that is from NMCH Patna, Rahul Raj and Abhimanyu Kumar. NMCH Patna.
Team D.
So all the 4 teams have come. First team is Team A from JLNMC Bhagalpur. Second team is from Paras. Third team is from AIIMS Patna, and fourth team is from NMCH.
One by one question pass
To answer if the question passes to you. Thank you.
So welcome all. So team A, B, C, D. All right. So because already we are running late, so we are not keeping the passing the question round. So it will be 1 question, 1 answer, no negative marking. So team A is a pictorial round. Clinical. I will give a short history. 50-year lady has pain in right ankle on the medial aspect. So what is this name of this sign? Team A. No prompting. So all right. 0 for team A. From audience, anyone of you? Yes, this is 2 money toe sign that is seen in tibialis posterior dysfunction. All right. Yeah. So 2 money toes. You can see 4 toes there. Normally from posterior aspect you can't see. It's because of it's like a plantar valgus deformity in the ankle. Got it? Team B. 25-year female. Listen. Scoliosis. Scoliotic deformity. 10 points for team B. Team C. 15-year girl. Had a deformity on the left side. They loud. Genu valgum, 10 points. Team D. 12-year-old boy had a history of fracture around the elbow. Alright, so we'll start with team D. Alright, team D ready? And no prompting from back. Yes. So 10 points for team D. Team C, no prompting. Team B, no prompting. We got that. So I think pictorial round is very easy. Team A. 10 points. Yeah. Pylon fracture. Done. Next round. We are doing it fast because we are constrained after already we are running late and we have to conclude the liquefaction also. I know MRI reading. As you know, you should know your MRI reading. You should read the MRI and you should read the. As we are clinician, we should read patient also and see patient also, and then we should know how to read your MRI. Because for X-ray, any of you didn't need any radiologist report here. All of you are diagnosed by yourself. And same way, just train your eye to see your MRI and report your MRI by yourself. So this is an MRI reading now, and I have named it, I know my MRI reading. 40 men, 20-year male child had a history of bike accident, has a typical bumper has hit over the knee. So what is the clinical diagnosis? This is a sagittal curve P2 weight image of the knee joint, left knee. For audience, alright, it's a PCL aversion, you can see, and the classical history is dashboard injury. Dashboard injury is a posterior translation force is there, and you have an aversion. You can see this whole of the fragment has avulsed from here. Team B, 25-year-old male had a history of playing football, twisting injury, came with your clinic with pains and symptoms of instability. Yes. Team B, yes. Be loud in your answer. Be loud, huh?
ACL.
Yes, it's ACL tear. So anything which is parallel to your broom straight line, you can see here, should be your ACL. Normally the ideal cut is 15-degree oblique sagittal cut. So you ask your radiologist for this cut particularly, because most of the radiologists will do normal sagittal cut, and you can see whole profile of the ACL. You can see the distal part, but the proximal part, the ACL profile is not there. That is suggestive of a complete ACL tear. Good. Team C, 50-year male had a history of pop-up sound around the shoulder. Patient has a clinical symptoms of classical. He has a drop of sign positive. Your MRI, this is sagittal cut of the MRI of the glenohumeral joint. Yes. Which part? Yes. This is a complete tear of the supraspinatus. So you can see here, supraspinatus fossa, the supraspinatus is coming here. This is your beta tuberosity. So complete tear of the supraspinatus is there. Whole of the supraspinatus has retracted here over towards the glenohumeral joint. So it's a complete tear of the supraspinatus. Well done. Team B, 15-year-old boy had a history of anterior shoulder pain with some history of pop-up sound around the shoulder. This is the axial cut of the MRI of the shoulder. So point. Yes, bank cut. So bank cut is a classical anto-inferior lateral tear. So how you identify anterior part? You can see this is your subscapularis and your biceps is your best guide. The black one is your biceps tendon. So that guides you. Yes, this is my anterior part. Sometimes you may get a coracoid also in that view. And you see this anterior labrum is peeled off, and the white line is posterior labrum. So there is a complete peel off of the anterior labrum, which is suggestive of a classical bank cut. On at the end of the second round, the third round.
Team A is 10, Team B, C and D, all 30 points.
Alright, so I think now I will ask Dr. Rajiv Anand sir. He will conduct the fastest in the round. If time permits, we have a video round also. So this is a classical video round. Yes, wait. Again from Team B. You will get your chance. Don't worry. And you have not seen the video, raise your hand. So, just team A. Yeah, you can see here, this is a patient has a symptoms of instability. So, wait. Team B, yes, Team B. Yes. So, just see this video. What is the name of this? First, this one. You can see the classical sign is
Speak in the mic.
Speak in the mic. And what is suggestive of? So this is anterior door, alright. And this is the posterior door. And classical, you can see the sac sign here is suggestive of PCL injury. 0. Team C. Patient has history of locking episode, and patient came to you in your clinic with 15-degree flexion deformity of the knee, and it's like you can't extend the knee. And once you put your take this patient to the OT, put your scope inside, you can see there is something entrapped in between the condyle. What is this? Classical. This is a pocket handle here with locking of the knee. You can see this is classical locking. You can see here the femoral condyle and the tibial condyle. The whole of the meniscus is entrapped. That is called locking of the knee. तो आर्थोस्कोपी होता है तुम्हारे यहाँ yes 35-year male team B next question team B. So 35-year male had a history of road traffic accident, and you can see here the patient has classical symptoms of instability. Just you have to name the test here. You can see what is the name of the test, just name of the test. What we are assessing. Instability of the knee. Audience? Dial test is for posterolateral instability of the knee. Normally what happens, normally you have 15 to 20 degree of external rotation is there in the knee joint. If you have excessive external rotation, that suggests yes, there is some amount of rotator instability, and it is because of your LCR and posterolateral corner injury. Most important component is your popliteus injury. Alright, an oblique popliteal ligament. 0 for team B. Last video round. Again, this patient has symptoms of knee instability. You have to just name the test. Name the test. No prompting. Be loud. You are orthopedic surgeon, huh? Be loud.
Speak in the mic, please.
Loud. डरना नहीं, orthopedics में तो डरना नहीं है, ठीक है? Yes, this is a classical varus test, and that is for your LCR injury. And normally we do it in 30 degree of flexion, because that is the in that position of the knee the collaterals are maximum tight. All right. So that is it. So 10 points for team A. So at the end of video round, Rajiv Anand sir, at the end of video round, what are the marking?
And team B is 30.
Very close. So now I think Rajiv Anand sir will come.
Questions you have to answer in 2 minutes, and question doesn't pass, and one team has to answer continuously all the 10 questions. If you don't answer, you don't have an answer for a question, just say pass. We move on to the next question. Okay? It's clear? We have 10 questions in 2 minutes. If you don't know the answer, just say pass, and we move on to the next question. So that you can save the time. Save time.
Yeah.
Move on to the next
You
question.
can save time.
Next question may be easier.
Yeah. So I'll repeat this, that this is a rapid fire round, and maximum 10 questions have to be answered in 2 minutes of time. You have to be very prompt. 5 marks for each correct answer. There is no negative marks. Next question will be asked if you answer or pass. So be very prompt. Question does not pass on. So are you ready? So I will start with team A.
At 2 minutes, I
Two minutes time is there. So your time structure that anatomically reduced and fixed with cannulated screws have an osteonecrosis rate of 15%. It's true. Right. Name the abnormal radial or ulnar angulation of a finger.
Please answer in the mic.
Answer or pass? Pass. Splenodactyly. Chondroblastoma of the proximal humerus is known as which bone tumor? Pass.
In the mic, please.
Say in the mic whether it is pass. Pass. It's Codman's tumor. Name the genetic factor of pauciarticular juvenile rheumatoid arthritis. Please be loud here. Pardon? HLA-B?
HLA-B 27.
27. No, it's wrong. Answer is HLA-DR5 or 8. ulnar positive variance is associated with key box disease. Is it true or false? No, it's false. Its biomechanical factor is ulnar negative variance. Name the segmental nerve levels correspond to sensation at the xiphoid process. D4. No, it's wrong. Answer is P7. The inheritance pattern of polydactyly is pardon? Autosomal recessive is the right answer. Name the metabolic bone condition looking at the X-ray. No, it's Paget disease. Your time is off. So there's a question to the two questions left for the audience. Stress fracture is best diagnosed by MRI is the correct answer. After whose name a smart bandage is famous? It's August von Smart. Team B, are you ready for that? Absolutely ready. You feel very prompt. See, they have missed these two questions because of time. Yeah. If you don't know, just pass it. So your time starts. Anup, you are ready? Your time starts now. The stance phase occupies 40% of the gait cycle. True or false? True. No, it's false. It occupies 60%. Anterior cruciate ligament is true or false? No, it's false. It's a contraindication of unicompartmental knee. Bone cement act as a glue between implant and bone. True or false? Absolutely wrong. It acts as a glue. It doesn't it acts as a grout. So a 13-year-old fell off his bike. Identify the pathology. Slip capital femoral effusion, absolutely right answer. What radiographic finding may indicate a medial collateral ligament injury? Pass. It's Pellegrini stadial lesion. During medial meniscus repair, what structure is most commonly injured? Pardon? Pardon?
ACL is the answer.
No, it's branches of saphenous nerve. Optimum position of flexion to perform hip arthrodesis is very easy. 30 degrees is the correct answer, 30 to 40 degrees. The necessary daily calcium and vitamin D intake in patients between 19 and 50 years of age is 500 calcium, wrong, and vitamin D is also wrong. Which organism is most frequently found in patients with an infected humoral non-union? Pardon? No, Staphylococcus is wrong. It's Propionobacterium acnes. Who devised the point of osteostrone for the audience? For the audience, William Macmillan. So team C, are you ready for that? So ready? Treatment for hypertrophic non-union in intramedullary nailing of long bone fractures is cancellous bone grafting. True or false? False. Absolutely right. It's exchange nailing. Chronic iritis is seen in which orthopedic condition? RA is, okay, right is JRA. You can give 5 marks. Which non-malignant soft tissue lesion can mimic soft tissue tumor? Pardon? GCT. No, it's myositis ossificans. The pelvis shown in picture for right acetabulum. Pardon? Zooted view is absolutely right answer. How many grades of ligamentous injuries are described according to O'Donnell? No, it's 3. Mild, moderate and severe strain. Which part of the femur is usually osteotomized in hip osteotomy? Pardon? Proximal, no, you have to give the part. Intertrochanteric part, you can give 5 marks to that. During a posterolateral approach to the elbow for fixation of a proximal radius fracture, the posterior interosseous nerve is safest with the patient's elbow and forearm in what position? Only prone? Flexed and prone, absolutely right. Which compartment is most commonly involved when a leg muscle hernia is present? Posterior is absolutely wrong. Answer is lateral compartment. The main deforming force in the Bennett fracture dislocation of the thumb is due to the pull of. Pardon? Bennett's fracture. Abductor what? Pollicis longus, right? You can give 5 marks. What is the central point of the body? Last question. Oh, it's for the audience. It's umbilicus. Team B, are you ready? 10 questions in 2 minutes. Are you ready? So your 10 false. False is a very right answer. Gastrocnemius is major deforming force in supracondylar femoral fractures. True or false? No, it's true. In Ponseti method, the goal of the first casting session is to correct the cavus deformity. Is it right or wrong? True. Absolutely right. Which structure is at risk for injury with any varus or adduction force to the knee? Pardon?
In the mic, please speak in the mic.
No, it's peroneal nerve. The most is TAD is absolutely right. What is the most common indication for pelvic osteotomy? DDH is absolutely right answer. What is meant by anterior column of the sternum? Pass. It's iliopubic column. Segmental level in the innervations of quadriceps muscle is L2 is right answer, but it's L2, 3, 4. Right. What is the diagnosis? Rocker bottom foot, you can say, but it's a congenital vertical talus. You can give 5 marks. Time up. So patient's fears of adverse effects of a drug is known as which effect? No marks will be given, but from all those 4 participants.
Anybody?
Anybody?
You get a bonus 10 marks from my side. But I am not the scorer.
So now it's amygdala effect. So thank you very much. So the scorer for the rapid fire round, how much?
The lowest score is 40 and the highest is 85. Team Bhagalpur. Next is Team B from Paras, that is 50 marks. And this is the third position. The second position is by Team D from NMCH, that is 70 marks. And highest marks 85 is Ames Patna, the team from Ames Patna. Congratulations to all the teams for participating, and also congratulations to all the participants who were eliminated for your participation. Thank you.
Congratulations, sir. They will be sending in the national quiz contest in the next IOCON. The Bihar Orthopedic Association will give the to and fro. Whatever the expenses will come as a lump sum amount, we will give to the both of you. So that comes to
around 5 to 7,000 rupees. And in the valedictory function, you will be getting gold medal, silver medal, and bronze medal by our president. And the third thing is, our dynamic organizing secretary, Dr. Madhusudan Kumar, is very humble and very happy with you all. He will be giving you the cash prizes.
And
So the first team will get 5,000 rupees from Vaishali Orthopedic Club. The second runner-up will get 3,000 rupees, and the third runner-up will get 2,000 rupees from Vaishali Orthopedic Club, presented by Dr. Madhusudan.
we would like to have the third prize winner.
And now I will request our IOS secretary to come on the stage.
The team who has come third, please come on the dais. This is the team from Paras.
Start from the fourth one.
Dr. Neeraj Raj and Dr. Pushpinder Rathore. This is from the organizing secretary, Vaishali Orthopedic Club. And then we have the second prize winner from NMCH. And they are Rahul Raj and Abhimanyu Kumar. And the first prize winner from AIMS Patna, Mohit Verma and Swam Prakash Das.
Now I will call upon Dr. S.N. Sarraf, President Bihar Orthopedic Association, and Dr. Bharat Singh, sir, President Bihar Orthopedic Association, and Dr. Mahesh Prasad, Secretary, BOA, to come on the stage and will not disappoint the fourth who have come fourth. So please come on the stage, those who has attained the fourth position in the BOA quiz.
First prize.
The second position, who have got, please come on the
Second
dais.
prize from NMCH, team from NMCH. Equal sides. Successful.
And the third position is from Paras Hospital, Paras HMRI, third position. Please come on the stage and collect your prizes.
And from IU, I have a small request that please become the associate member. Yes. You will get the form from the secretary of Bihar Orthopedic Association. So please become the member, associate member at least, and then become the life member.
And now a consolation prize to Team D. Please come on the stage.
Team D.
Team D.
Team D.
Team A, sir.
Bhagalpur.
From Bhagalpur.
Jawaharlal Nehru Medical College.
And there is a
This is
disclaimer
where
also.
the PG could eliminated.
And there is a disclaimer that I have had.
Be there in the valedictory function, you will be getting the medal.
So it was not a
The
fixed
PG
match.
session will now start in Hall B.
Also, I would like to inform the House that team from AIMS Patna is going for the second consecutive year to IOA quiz. Last year we were at 4th position in All India IOCON. Thank you.
Chairpersons for the R.R. Ganguly Three-Paper Gold Medal Award session. Dr. Rajiv Anand. Dr. Rajiv Anand sir. Dr. Rajiv Anand sir. Chairperson for the next session. Dr. Bharat Singh sir. Dr. Bharat Singh sir. Dr. Mahesh Prasad sir.
I will just tell them. Please, audience, please take your seat. Please take your seat, sir. Please have a seat, Roshan. Please tell everyone to sit. Dr. Manoj Chaudhary, sir.
Hello.
Good afternoon, everyone. My paper is on the role of stem cell therapy to CC screws and the management of AVM of femoral head. It was first described by Munro in 1738, and this is a state with multiple etiologies that causes a decreased vascular supply to all or a portion of the head, resulting in the death of osteophytes. It was also called the pulmonary disease of the hip, and it is the final pathologic response, and it has a variable progression and extent of involvement of the head. Now coming to the demographics, it mostly affects the young adults. Males are more affected, and there is a bilateral involvement of the head. And overall, 18% of total THRs are performed for AVM. This is the blood supply of the femoral head. The risk factors for AVM include the end arterial supply and lack of collaterals and the other things. Coming to the pathological classifications, the causes are arterial insufficiency, venous occlusion, intravascular capillary occlusion, and intramedullary factors. We know iatrogenic causes are the most common causes. Second is trauma, alcohol consumption, and corticosteroid intake. We have seen that this was very important during the COVID-19 pandemic. And coming to the steroids, which is the use of steroids, which has a major role in orthopedics, as we have seen. Steroids cause adipogenesis and they reduce the vascular endothelial growth factors, and they also reduce the number of precursor stem cells. That is why they lead to AVM. This is, as mentioned in JDJS, for diagnosis of early stage of osteonecrosis, the risk factors include trauma, radiation, chemotherapy. Associated with the risk factors include corticosteroid, alcohol abuse, etc. What is the aim of the treatment? The importance of the early diagnosis is very important here. We should preserve the hip rather than replace. Other thing is standards for identifying and staging osteonecrosis is very important. We should assess the efficacy of various treatment modality, and we should provide a recommended treatment algorithm. This is the staging system for osteonecrosis of femoral head. The most common being Siget and Arlett. Others are ARCO, University of Pennsylvania, and others. The treatment modalities are mainly conservative and operative. As we all know, the treatment recommendations include till 2A, we do a core decompression with bone grafting. For 2B, we do bone grafting, and beyond that, osteotomies and hemiarthroplasty, and for stage 4, total hip arthroplasty. Now, in our study, we use progenitor cells, and this was first used in 1985 in France. And the pioneer was Havio and Boacon in 1993 who defined it, and the results were first published in 2002. This was the article where they published that after 5 or 10 years of follow-up, only 9 hips required total hip arthroplasty among 189 hips treated with core decompression along with bone marrow. This was the other study by Yanchi, where 62 patients of stage 1 and 2A AVA were treated with bone marrow stem cells harvested from interior iliac crest, and at 5-year follow-up, 72 out of 78 hips had satisfactory results. This was a 30-year follow-up of the same study. Now coming to pathophysiology, there is increase in fatty marrow in intercostal region in osteonecrosis, along with abnormalities in stem cells, which leads to adipogenesis and decreased stem cell pool, and leading to altered intramedullary vascularity and lack of osteogenic cells, leading to osteonecrosis. The stem cells, the more the number of stem cells in bone marrow aspirate, this increases the osteogenic properties. Bone marrow stem cells, they secrete angiogenic cytokines, and they are anti-apoptotic, anti-inflammatory, immunomodulatory, pro-angiogenic, proliferative, and have chemoattractive capacities. Our study was performed on 60 patients, including 48 males and 12 females, and the mean age was around 29.4 years. The patients were classified on physiognomic grading as 1, 2, and 3, and pre-operatively hematological and radiological investigations were done. Pre-op modified Harris score was calculated. We harvested the bone marrow mesenchymal stem cells from the iliac crest to percutaneous aspiration. The site was from the apex of ileum around 4 cm posterior to the ASIS from a sheathing needle. Around 50 ml of aspirate was taken in a pre-heparinized syringe and centrifuged. We drilled the femoral head through a lateral incision, and the guide wire was advanced, and over that a cannulated drill was passed, and we used a 6.5 mm CC screw over it. And then we introduced the concentrated marrow through it. Around 10 to 15 ml of marrow was inserted, and we removed the CC screw by 2 turns after injecting every 2 ml of concentrate. The procedure was repeated again after 1 month, and follow-ups were performed at 1, 3, 6, 12 and 24 months. MRI was performed at 12 and 24 months. Results. Males were more affected than females. Average age group of presentation was 29.4 years, the mean being 22 to 25 years. The most common cause was idiopathic followed by steroid use. The mean Harris score improved from 69 to around 90 at the end of follow-up phase, that is 2 years. The results were excellent in more than 95% of cases at 2 years follow-up. And only 2 hips required total hip arthroplasty at the end of 2 years. Now, why is our study important? See, there are many non-surgical interventions which have been used for the treatment of AVN. Now, coming to pharmacological agents, we have used lipid-lowering agents, anticoagulants, prostacyclin analogs, and bisphosphonates regularly. But the clinical failure rates come to around 10 to 50%. And our study showed that the failure rate was very less. Coming to electrical stimulation, in a meta-analysis of 10 articles, good to excellent results were seen in only 60% of cases. And our study showed a better result in that. Use of vascularized fibula graft has been done by many people. In a study, it showed that around in 151 hips undergoing vascularized fibula graft, 124 were followed up for around 10 years, and the Harris hip score improved from 72 to 91. Our study showed the range to be similar without having undergone such a extensive procedure. The use of vascularized iliac bone graft was also performed, and our results were as comparable to the same. The effect of intra-arterial delivery of autologous bone marrow had the same effect. And coming to shortcomings, we have the urge to operate now, rather to, and we had a reluctance to conserve. That is the main shortcoming on our part. There is a minimum short-term follow-up, less number of cases, and there was no standard technique of bone marrow concentrate preparation which was followed, and the dilemma of keeping the bone marrow concentrate in place. Now, how can we improve? We should plan for conservative multimodal treatment in early osteonecrosis. We should include a large number of cases, and proper follow-up and record keeping is a must. Thank you.
ABN early.
So, on the basis of the main diagnostic X-ray and MRI. Early is bone scan and MRI.
So you have trained it and bone marrow concentrate you have injected.
Yes.
So do you think that this helps? What your studies say?
Sir, individually it doesn't help. Sir, it is an augmented procedure along with core decompression in early stages.
My question is, how can you assess your this sort of treatment is working?
Sir, we have assessed using Harris score, sir, modified Harris score. Sir, the functional criteria for improved pain, function and functionality. So all three components are assessed there. Which is the, and sir, overall radiologically also we assess for the progression of the disease. After the end of the follow-up, we assess the radiology, and so in most of the cases, the final and initial X-rays were the same of the same stage.
I mean to say the most important aspect you ask the patient how you feel after the treatment.
Sir, improved functionality and improved pain.
In your study, which TCAT you chosen?
Sir, we chose up till 2A, a few cases of these, very few. Thank you, sir. 98 cases, 98%. So 60 cases, sir. And percentage of improvement. 95 cases.
I thought it is the best approach to treat the osteonecrosis.
No, sir. Sir, our study was only done in 2 years, sir. So, sir, in early cases, we can prolong the treatment, sir. Sir, our general tendency is to not conserve, rather than we operate the cases mostly. So, sir, we have already, all of us, we generally practice core decompression, sir. But this is an augmented therapy along with core decompression that we want to facilitate.
Whatever therapy may be, but result is 95% good.
Sir, after 2 years, that is what we found.
Excuse me. Every time you put that cancellous screw, like first month, third month, 6 months.
No, sir.
Then?
No, sir. Sir, we did that only twice, sir. Sir, the problem was we could have done it only once, but the problem is that the bone marrow aspirate, sir, there is a doubt among people that it doesn't stay at the same place. The concentrate, it doesn't stay at the same place, it generally leaks out. That is what people say. So we repeated the procedure after 15 days again.
So you put the cancellous screw there?
Yes, sir. So there are specialized cancellous screws for that, which are valvular, but those are not available everywhere. So we use the normal CC screw, and they, after every 2 turns, after injecting every 2 ml, we just rotated it backwards every by 2 turns. Yes, sir. So that the aspirate stays there. But there are specialized valvular screws also, which help in injecting the bone marrow aspirates.
So don't you think that the aspirate will come out with the cannula?
So that is what a lot of people have a doubt, that it comes out in the some muscle thing. So we repeated the procedure after 15 days again.
So finally you take out this too?
Yes, sir.
So why don't you put the normal bone which you have taken out from the core decompression and just plug it?
So we did that after. So but there is still some doubts whether it will stay or not, because it's a liquid, sir. So that is what people say. So we repeated the procedure.
bone wax.
Sir,
You seen it?
sir, we tried, sir. We tried, sir, but it was not a standard procedure and it was not mentioned anywhere. So,
What is wrong with bone wax? Is there any wrong thing?
sir, it is not wrong, sir, but I could not find any article.
It will seal the hole.
Yes, sir.
It will seal the hole.
It will seal the hole. The point of entry, if you put a bone max, it will seal.
No liquid will come out. When you put the bone wax, it will not come out. It will remain there.
And
Thank you, sir.
one more.
Thank you.
The aspirate you take only from the iliac crest or from the tibia also,
Sir, in some cases where we could not get enough aspirate, we did from TB also, sir.
and the processing process is done in a normal way,
Sir,
or it is
sir,
a
actually-
slight room.
Sir, actually, this process is not standardized, sir. Everyone follows his or her own protocol, sir. So there are multiple protocols, but we had our own protocol, and that is what we did. So after researching from some 3 or 4 places, sir, that is what we came to. But that is the problem, sir, that we have no standard protocol, and the use of orthobiologics is not, sir. The use of stem cell therapy is not standardized anywhere in the world, sir. So there are different procedures that everyone follows, whatever he or she thinks. That is the problem, sir.
So it is simple procedure to prepare
Yes, sir.
that.
Yes, sir.
whatever
Sir, we
used to
use
put in the tennis elbow and all.
Yes, sir. Sir, the way we prepare PRP, that is how we prepare bone marrow stem. But the problem is that there is no standardized procedure, protocol. That is the problem, sir.
Thank you, Anand.
Thank you, sir.
I think you should do more number of cases and let us know in our next work. Thank you.
Originally, locally, have you tried it?
I'd like to call Dr. Vishal Anand from Jammu. He is speaking on surgical management of bimanual fracture in adults, its results and complications.
Respected chairperson and delegates, on my study of surgical management of bimanual fractures in adults with results and complications. My objectives were to study the functional outcome result of surgical management of bimanual fracture in adults and to know the complication of open reduction internal fixation in bimanual fracture. Patient between 20 to 60 years of age and age of injury less than 20 days old were included in my study, and posterior malleolar fracture, vertical compression fracture, cup fracture, pathological fracture and compound fracture were excluded from my study. A prospective study was done from July 2001 to July 2021 in about 20 patients, in which casualty and OPD patients were mainly included, and maximum follow-up period was done up to 6 months after the operative management. Necessary routine investigation was done. Diagnosis was confirmed by anteroposterior, lateral and mortis radiographs. Stabilization was done with below knee slab, and ORIF was done. One skin condition was good and swelling has subsided. Assessment of result were mainly done by Baird-Jackson scoring system. Mainly elderly patients were included, about 10 out of 20 were in between 50 to 60 years of age. Male to female ratio was 3:2, and mainly agriculture workers and farmers were mainly included. Right side preponderance was seen in my case study. Mode of injury was mostly road traffic accident. Type of injury was categorized and determined by Lord Hanson's classification, out of which 8 out of 20 were having supination external rotation injury, and 6 each having supination adduction and pronation abduction injury. These are the pictorial depiction of the mode of injury, that is supination external rotation, supination abduction, supination adduction, pronation external rotation and pronation abduction. Implants used for fixation: for lateral malleolus, 1/3 tubular plate was used in 10 patients, rush nail in 3, cannulated cancellous screw in 4, and tension band wiring and reconstructive plate were used in 1 and 2 patients. Implant used for fixation in medial malleolus was cannulated cancellous screw in 12 patients, tension band wiring was done in 4, malleolus screw in 2, and anti-glide and buttress plate were used in 2 cases. Under tourniquet control, lateral malleolus was fixed first through lateral approach, and anteromedial approach was used for medial malleolus. Soft tissue dissection was done, and fracture was reduced with towel clip and under image intensified and proper implant was put and closure was done. These were the implant and instruments used in my study. Intra-op image of lateral malleolus, I am showing this, and also the intra-op images of medial malleolus. Immediately after operation, the X-ray were taken, parenteral antibiotics were given up to 2 post-op day and range of motion of exercise and non-weight bearing ambulation using actually clutch were given from right from second day, and patient was followed up at 4, 9, 12 and 24 weeks for radiological evaluation. In final results at the end of 24 weeks was taken by the and calculated using Baird and Jackson scoring system. This is the Baird and Jackson scoring system, that is the 7 category in this scoring system were given alphabetical grades, each being assigned a point score. That is categorized as pain, stability of ankle, ability to walk, ability to run, ability to work, motion of the ankle, and last the radiographic result. Final score according to the subjective and objective radiological criteria are shown in this table. That my patient has got pain in almost 14 cases in category A, and likewise you can see. Functional and radiological evaluation were done mainly through physical examination, radiological examination by active dorsiflexion and plantar flexion with 4 parts of foot in neutral position, and radiological examination was taken seen by seeing the medial clear space, superior joint space and talar shape. The entire tilt was measured. The final outcome of my study were categorized in 4 groups, that is excellent, good, fair and poor, out of which 75% of my patients were having excellent result and 15% were having good results, and 5 each were having fair and poor. At the end of 6 weeks and 6 months, progressive increase in the plantar flexion and dorsiflexion were seen in my study. Final result were compared to the other studies, and my study has 90% good to excellent result as comparable with the other international studies. These are some clinical photographs of my cases. That's case 1 that has fair result. You can see the excellent result, the dorsiflexion, plantar flexion, abduction, external rotation. My case, this is case 4, this is 5, 6. These are the complications that are theoretically expected in open reduction internal fixation of bilateral fracture, that is perioperative, early post-operative and late complication. But luckily I was having only one case with pulse discharge skin dehiscence. That means only 5% was one case was infected in my case. Coming to the discussion, the most common injury mechanism in bilateral fracture was seen superior external rotation injury. Most common etiology was road traffic accident. Understanding the mechanism of injury is essential for good reduction and internal fixation. Chance of non-union of medial malleolus due to periosteal interposition and that of fibula due to the soft tissue interposition should be avoided. And open reduction internal fixation in bilateral fracture gains good to excellent ankle flexion after 6 months by using Baird and Jackson scoring system. The take-home message of my study was to prompt and operative treatment of displaced ankle fracture leads to decreased morbidity and better outcome in the function of ankle joints. Unstable ankle motricity leads to significant functional problem because of the instability, ankle stability that is due to talar shift. And it is very important to store the ankle stability, the articular congruency including the medial impaction as seen in the supination adduction injury. The fibular length maintenance very much necessary for maintaining the lateral stability of ankle joint. And the bend of lateral malleolus while putting the lateral malleolus plate, fibular plate on the lateral malleolus to maintain the articular congruity is necessary. Thank you.
When you plan this surgery,
yes sir.
So you must have an idea of a mechanism of injury, as you can say.
Yes, sir.
So if the patient come with you with some X-ray,
Yes, sir.
and that X-ray you looks good, but seen a fracture in respect of your alignment and reduction. So do you have any role of conservative treatment in this type of cases?
Sir, conservative treatment in which, sir, ankle mortise is maintained, sir, and only medial malleolus fracture, undisplaced fracture are present. In that cases, sir, we can go for conservative management, sir.
Suppose the medial malleolus has been fractured and the periosteum has gone inside and again it has closed up. And in X-ray it looks hairline undisplaced. Would you like to go conservative?
Sir, there is a stress test by putting the patient in lateral supine position, sir, lateral position and hanging the foot. There is a tilt occurs due to, sir, that shows the deltoid ligament.
I'm just asking if the periosteum has gone inside.
Yes, sir. Yes, sir.
It has been closed. But after in X-ray you are seeing undisplaced medial malleolus. Would you like to go conservative or would you like
No,
to
sir, operative, sir.
Definitely you want to
Operative,
go. So my question is that which case of medial malleolus would you like to do tension band wiring versus screw or K-wire fixation?
Sir, horizontal fracture, line of fracture, it is horizontal. It will, I will go for tension band wiring, sir. And if the line of fracture, sir, it's vertical, I will go for buttress plating or anti-glide plate, sir.
I am asking about medial malleolus fracture.
Yes, sir, medial malleolus.
So TBW, if the line is horizontal, then you will go for TBW.
Yes, sir, because, sir, while putting the, sir, the two K wires, we are going perpendicular to the fracture side.
That's good.
Yes, sir. And, sir, if the line of fracture is vertical, sir, then it will be more effectively held by the, sir, buttress plate or anti-glide plate, sir.
The idea is that if there is a cognition and the fragment is very small, you should go for tension band wiring.
Okay. Thank you.
Next question is, as you say, the lateral malleolus fixed first, then medial malleolus.
Yes.
Why?
Sir, first, while we fix the lateral malleolus, sir, the talus subluxation, sir, it gets automatically corrected, sir, and ankle mortise is almost maintained, sir.
Hello. Suppose the acute fracture comes to you.
Yes.
It's an injury around the ankle.
Yes, sir.
How you manage? Number
Sir,
one.
First of all, I will examine clinically the patient, sir. If there is lot of swelling, then I will just put him on BB splint and give ice compression to maintain the skin condition, sir. And I will wait till the swelling subsides, sir. Skin condition is good. After in between, sir, I will take the radiographical images and plan whether to go for operative or conservative, sir. If it is in the line of operative management, then I will wait for to subside the swelling, sir, and betterment of skin condition to achieve my
And wrinkle sign to be developed.
Pardon, sir?
Wrinkle sign should be developed.
Yes, sir. Yes.
So suppose in POTS fracture, bimalleolar fracture, when will you suspect syndesmotic injury? By looking at the X-ray.
By looking, sir?
In a bimalleolar
X-ray.
fracture, when you will suspect?
Sir, when the fracture line of fibula is above the line of syndesmosis, sir, and means, sir, sir, pronation, external rotation injury, sir, in which, sir, the mode of injury is, sir, first of oblique fracture in fibula, sir, and above the...
He meant to say that how can you assess in X-ray?
Sir, by looking the syndesmotic joint, sir, the overlap, tibiofibular overlap, sir, that is up to 10 mm, and the space, the tibiofibular space should be less than 5 mm, sir. And sir, clinically, sir,
Is there any talo-medial malleolus distance?
Talomedial, sir, 5,
which increases?
Yes, increases, sir. The degree is also, sir, talocular angle, sir. The 2 degree and 2 mm distance, sir. The two parallel line we draw, sir. if it from right to left
And
side.
how will you confirm your diagnosis? How will you confirm your diagnosis?
So by stress putting
By stress radiograph. Good answer.
And
Thank you, Vishal. Now I would like to call upon Dr. Raja Anurag Boacon.
Good morning, chairpersons. Good morning, respected seniors and dear juniors. Today I am presenting ACL rehabilitation post. Today now I am presenting about ACL rehabilitation post arthroscopic anterior cruciate ligament reconstruction. How to proceed for the rehabilitation. The most challenging question following the reconstruction of anterior cruciate ligament for an orthopedic surgeon or treating doctor to allow patient for sports, or you can say the normal person for unrestricted daily activity. Many test batteries have been devised, many times sensors were there on that, but it is still a matter of great confusion. So there is no unique criteria regarding this, when to allow your patient for doing normal activity, unrestricted activity, or return back to sports. So in this study we are doing retrospective study, which has been already get operated earlier in IGIMS Patna between 2018 to 2021. In those years, whatever patient having got operated for ACL reconstruction, irrespective of, in our study we have done irrespective of their sex, irrespective of the graft choice for the reconstruction, we have called all the patients. Exclusion criteria was only multiligamentous injury. Okay. The future of the study is still ongoing study. We are calling all the patients and doing assessment. The person who has already returned to a sport, or who are planning to return to a sports, and who has not returned to a sport. Already till August 2022, we got 36 patients which got evaluated. Evaluation was done based on both subjective and objective assessment. Subjective assessment was done using IKDC International D Documentation Committee score. Further, it was done on Tigner's Lysone's criteria, how they are performing in this score. And objective study was being done based on the functional outcome, based on the limb symmetry index. Limb symmetry index, further laxity or stability of knee. Yeah, total patients are 36, in which male were 24, female were 12 patients. Mean age was 28.8 to plus minus 8.2 years. It ranges from 18 years to 38 years. In our study, the age criteria was 16 years to 40 years. Upper limit was 40 years. And side involved mostly were left-sided and the right side in case of 15. Follow-up period was ranges from 12 to 42 months. Mean was 25.5 plus minus 4.5 months. Subjective assessment done using IKDC score. In 30% performed in the category A and category B, in which the category A was normal and category B was near normal. Another 6%, which comprises of 14.6% were in the C and D, that was normal or below average performance. Another was Tigner's Lysone's criteria, in which the mean score was 90 plus minus 4.7. Ranges 37 to 100. In this, 28 patients performed excellent to good. Excellent were 95 to 100 and good score was 84 to 94 in our study. Below that was up to 70 was average and below 70 was poor. That were 8 patients, 22.2%. Excellent and good performing patients have shown better to result in the return to a sport as compared to average and poor performing patient. Now coming to the objective assessment. Objective assessment was done using the limb symmetry index, the hop test. Hop test was mostly done the single leg hop, triple jump hop and triple crossover. Further 6 meter time the score. Two scores were taken and mean was used for evaluation. In this 30% performed high score above 90% and 6 were less than 90. The person who were performing less than 90 have not returned to the sports and they are planning. Patient performing more than 90% soon they have returned to the sports or unrestricted normal activity. Another laxity was assessment using instrument KT 2000 arthrometer. In this, if the laxity was anteroposterior laxity was more than 3 mm, it was considered lax. If it is less than 3, it is a stable knee. Mean translation was 1.6 mm plus minus 1.52 and it ranges from 0.5 to 9 mm. 32 patients have a stable knee, 4 patients have more than 3 mm laxity, that is a lax knee. Another clinically it was again verified using the Lachman test. In this 30 patients shows less than 3 mm translation, 6 patients were more than 3 mm. Further pivot test was also done. In this 2 patients shows a lax knee. The patient who performed patient with a stable knee were more swing for the return to sports as compared to lax knee. Another patient reported outcome where like range of motion deficit was in 2 patients. One was showing 5 degree extension deficit and one was flexion deficit of 5 degree as compared to other knee. Another was the pain on the squatting. The person who showed a deficit in the flexion showed pain on the squatting, the same patient. Another were anterior knee pain, graft side pain and knee fusion was also there in the 3 patients. One patient, 2 patients showed the graft failure, both were because of repeated trauma and both were managed with the revision ACL reconstruction. Now coming to the return to the sports, total 24 patients out of 36 patients have returned to the sports or pre-injury level activity. It was 67.7%. 12 patients have not returned to the pre-injury level, in which 7 patients have shown poor result in the subjective and objective assessment in any of the 2. But rest 5 have shown better result, but they have not returned. It is unexplained, mostly due to psychological. Fear of pre-injury is there, so mostly they have not returned. It's a matter of investigation again. Another the performance. In this study, we are sharing our experience regarding the return to sport or allowing the activity and the secret how we can proceed that might help the surgeon in making decision making, then to allow the patient for their unrestricted activity. The return to sport criteria as per my study would be if LSI is more than 90%, knee is stable, full range of motion, painless activity without swelling, and performance better in the objective assessment. A study is still under the process, so can I have 1 minute? The study is still under process, so it will mature with the time as the study will progress on. Another time, I think I want to show the time, role of time. It is quite variable. Many studies show that after 6 months we can allow, many show 12 months, some 2 years, because the graft failure rate is much more in the first 2 years. So many studies are there, but chance of injury risk is reduces 51% for each month given for rehabilitation. That's why after 6 months the chance of re-injury is very less. So person should be given at least 6 months.
Your time is up now, so I may ask some questions for you.
Yes.
So you have a very good presentation. My question is many things, either objective or subjective assessment. So which assessment is you like most and most crucial for the patient?
Functional assessment by limb symmetry index. I found this is the most appropriate, in which the muscle power along with the coordination both is being tested.
Symmetry, what does it mean, symmetry?
Limb symmetry index, hop test. This I found both power and coordination both is being tested.
So you can say this is the most important
Most
aspect.
important.
My question is, which type of patient needs this type of assessment, especially a normal person which is working daily pursuits of their life, or some high demanding patient like a sportsman?
Normal person, when we have to allow normal person for unrestricted daily activity, we should allow him only if he is performing limb symmetry index more than 90%. Otherwise, the chance of re-injury is there. That's why. In case of a sport person, it is definitely needed. And return to a sport, and again further we can allow for return to competitive sports. Most of the studies show 66% return to sport, but return to competitive sport is still 33%, and that rigorous rehabilitation and assessment is needed.
Your assessment is less than 3 millimeter and more than 3 millimeter. So more than 3 millimeter translation.
In the laxity, as far as the laxity is concerned, sir.
Do you think that 3 millimeter you can assess clinically?
With the KT 2000 arthrometer, we can assess.
Arthrometer?
Yes, sir.
Not clinically.
Clinically, it is difficult to assess. We can compare with the previous only, but with the ligament arthrometer KT 2000, it can be assessed, sir.
Hello, my simple question.
After how many days you allowed for rigorous activities?
Minimum 6 months, sir.
Minimum 6 months you allow for the basketball?
No, minimum 6 months we will assess, sir.
Yes.
After assessment, once he is performing more than 90, then only we can. It may go up to 2 years also, sir.
Usually everything goes well. Then
Yes.
after 1 year you can allow for the rigorous activity or sports.
Yes, sir. Competitive sports mostly after 1 year, sir.
1 year. Thank you very
My
much.
simple question, Raja and
Yes,
Raj.
sir.
At the period, after how many days of surgery, you allow active movement, partial weight bearing and full weight bearing?
Yes, sir. We are different person have different protocol, but the protocol which we are following from the day 1, we can allow first 30-degree ROM, and after 2 days, when the first dressing is being done, if everything is okay, like showcase or pain is bearable, we can allow further 45-degree for 1 week. And at the time of suture removal, approximately 2 weeks, we can allow up to 60-degree if pain is tolerable. And by the end of 1 month, 90-degree, or depending on most of the patient perform 90-degree by that time. If patient is cooperative, we can go for full range also, sir. We are getting also.
And what about the weight bearing, partial and total weight bearing?
Weight bearing, day 1 full weight bearing. If meniscus involvement is there, then only we have to get. Otherwise, day 1 full weight bearing. Thank you, sir.
Good luck, sir.
Topic for today's presentation is explorative study of vitamin D deficiency in elderly patient and its association with hip fracture. As we know that the elderly people are more vulnerable to trauma due to their reduced reflexes with aging process, and hip fracture is more severe fragility fracture associated with remarkable increase in morbidity and mortality. Postmenopausal women are higher incidence of osteoporosis and fracture due to deficiency of estrogen. As we know that the vitamin D is the most important vitamin for bone health, and serum 25 hydroxy vitamin D is the best indicator for vitamin D. As we know, less than 20 nanogram per millimeter leveled as vitamin D deficiency. And the study is done because only limited data is available on the elderly patients with vitamin D deficiency here. The aim of the study is to study the serum level of 25 hydroxy vitamin D in elderly patient with and without hip fracture, and to study the osteoporosis in elderly patient by knowing BMD and fracture score, and to study the any association between the vitamin D deficiency and osteoporosis. The study center was the LLR Medical College Meerut, and the duration between the 17 and 18. The total 100 patient was taken, and the study design is prospective, analytical and case control study. The inclusion criteria are the elderly males who are more than 60 years without hip fracture, postmenopausal women more than 50 years with and without hip fractures having amenorrhea for last 12 months, and who is able to give written informed consent and doesn't take the supplementation of vitamin D for last 1 year. Exclusion criteria are hip fractures secondary to tumors, periprostatic and high energy trauma, and the patient with comorbid condition like renal insufficiency, malabsorption, active liver disease and patient on medication like glucocorticoids, androgens and anabolic steroids. Elderly patient with dementia or who suffered cancer within 5 years, or patient having more than one fractures, or patient receiving estrogen replacement therapy or any infection. We exclude the patients from study. We took the two groups, case group and the control group. Case group in which patient with hip fracture and the control group in which without hip fractures. All participants were questioned and examined in person. The BMD and the blood investigation like 25 hydroxy vitamin D is done for all patients, and vitamin D level was assessed by using Hollick's classification, and bone mineral density was measured by DEXA scan for hip and was documented in the form of T score and Z score. The tools for statistical analysis by using the software SPSS 25, and for intra-group comparison we use mean, chi-square and Winn-Whitney test, and for comparison between the two groups we use t-test. The observation and result, we taking the 50 patient in case and the 50 in control group. The age distribution between the study is quite good. The 50 and 60 years constitute of the 36% and the 60 to 70 year patient constitute 40%. The same for the cases and control, the mean variables. The sex distribution is also quite good. The 58% and 42% male female in cases and 44 and 56. The group statistics are the mean variables for vitamin D is 35% for cases and 22 for control, and as compared to BMD the 1.83 and 2.73 for respective cases and control, and similarly for fracture score 5.63 and 7.86 the mean value for both. The osteoporotic determinants are the BMD fracture score as compared to the male and female. As from the discussion part, we discussed our study with several studies and observed that the lower the vitamin D concentration in individual with fractures in comparison to control group, and there is the Cummings also stated that the site specific measurement of BMD at hip was better predictor of hip fracture than the measurement at other skeletal sites, and also the study suggested that the fracture score is used to identify the possible threshold for any intervention either therapeutic or preventive in major osteoporotic fractures. The conclusion of the study is the elderly patient who presented to us with hip fracture had low concentration of vitamin D and high chances of fragility fracture as compared to control group. The elderly patient who suffered hip fracture have low BMD value and high fracture score as compared to control group, and the correlation between the osteoporosis and vitamin D is established. Lower the value of vitamin D, there is the higher the chances of osteoporosis. There are few limitations in the studies because our hospital is tertiary care center, which does not represent the whole strata population. In our study, we also doesn't match the occupational lifestyle and education of the patient on both groups. The study could not assess the when and how long the vitamin D deficiency in these patients.
Vitamin D3 in your
Sir, the dose of vitamin D is?
Dose of vitamin D.
Sir, 200 sir. Sir, daily dose is 200 sir.
You are giving daily 200 micrograms daily.
Pardon sir? 200 international units sir.
I want to know the dose of vitamin D3 in your case study.
Sir, actually the patient came to us with either hip fracture or not. We assessed the vitamin D level and then the study is conducted. After that the BMD of fracture score, we determined whether the patient have.
What is the dose I am asking? If you give
Sir, 200 international unit daily, sir.
Really?
Yes, sir.
Is there any tablet or capsule available in market?
For what, sir?
Any 200 microstars.
No sir, 200.
I am asking ki what tablet you are giving and how much. 200 microgram given not possible.
Okay sir. Sir, tablet calcium with vitamin D.
200 international unit you are meaning.
Yes sir.
So that is the normal requirement of everyone.
Yes sir.
Right?
Yes sir.
So, but in your osteoporotic patient where DEXA scan has proved that he is suffering from osteoporosis or osteopenia,
yes sir.
what dose you prescribe? That's what he is asking.
Okay, sir, we give in the composition the tablet, the calcium with vitamin D, sir. The calcium dose is 500 and the vitamin D is 400 international unit. Sir, this is not sufficient, sir. Calcium is 1200, sir.
No, vitamin D is sufficient. Shown level of vitamin D is 20 nanogram
Per deciliter, yes sir.
For that patient 200.
Sir, we give the bisphosphonate for that, those patients, sir.
Hello. My question is, how you assess risk factor with DEXA? They will write the T score at wrist is
yes, sir.
-1, T score at lumbar spine is -2, and T score at hip is -3.
Yes, sir.
How will you assess the risk factor? How you calculate?
Sir,
correlate the risk factor with the DEXA?
Sir, by FRAX score, sir. We use, sir, in DEXA, we use the central DEXA T score. If there is a T score between less than 20 and more than -2.5 is osteoporosis, sir.
How age of the patient is correlated with T score?
Pardon, sir?
Age of the patient is calculated applying the T score. How do you say that? Do you know?
Sir, T score is between the different ages, sir, because the most of the patient that we receive is more than 50 years of age. The T score is taken from the comparison between the adult, young adult. So in which the Z score is from the similar age group, sir.
J score is calculated in less than 50 years.
Yes, sir.
T score is calculated after 50
Yeah.
years. So we are asking about the T score.
Yes.
For your information, you calculate the lowest T score by DEXA and multiply with the age. If it is less than 100, it is low risk. It is between 100 to 150, moderate risk.
Moderate.
And more than 200 is a high risk.
High risk.
So this is what it is.
Yes.
Thank you. Okay, thank you, doctor.
Requested to go and stand beside their poster. The evaluation for a poster presentation is going to begin. I'd like to welcome Dr. Neeraj Raj for his presentation.
Good afternoon to all the chairpersons and respected senior and my dear colleague. Myself, Dr. Neeraj Raj, DMB resident, Paras Hospital, is presenting a paper on arthroscopic pull-out suture fixation for ACL tibial imminent avulsion fracture. It is a retrospective and prospective study comprised of 18 patients. Introduction: avulsion fracture of tibial imminence with ACL is an injury that most commonly occur in immature bone population. Untreated and displaced fracture can result in non-union, malunion or significant disability in form of flexion deformity, loss of extension or instability. Thus, operative treatment were suggested for this type of fracture. A variety of technique of fixation have been reported in open and arthroscopic fixation method, including K-wire, cannulated screw, intra-articular button, bioobservable nails, suture anchor, and transosseous suture. The arthroscopic pull-out suture fixation technique is the preferred treatment modalities nowadays. The objective of our study were anatomical reduction of the displaced fragment and achieving continuity of ACL fiber, adequate rigid fixation which allows early range of motion exercises, and eliminate the extension block and impingement due to displaced fragments. The material and methods used in the study was, the sample size was 18, all the patients provided their informed consent. The study duration was of 7 years and 6 months. Mean patient age were 25.5 years. The inclusion criteria included in this study was all the patients with complete ACL tibial imminent avulsion fracture that is confirmed by MRI and ability to walk and perform daily activities. before the trauma resulting in tibial eminence avulsion fracture. A minimum of 6 month follow-up. The exclusion criteria included in this study was patient with ACL injury associated with any other injury like MCL, LCL, PCL and meniscal injuries, avulsion fracture more than 6 weeks, open injury and fracture of any ipsilateral limb. Patients were evaluated on the basis of clinical history, clinical examination, radiological examination, that is X-ray, CT scan and MRI. The clinical examination that was used in our study was Lachman test, anterior draw test, the radiological examination. This is the X-ray showing AP and lateral. The arrow marks are showing that ACL avulsion fracture from the tibial spine level. The radiological examination used in our study was Mayer's and Macabre clavicle. This is of 3 types, type 1, 2 and 3. Type 1 is non-displaced, type 2 is partially or partially displaced, type 3 is divided into 2 types, type 3A and 3B. Type 3A is completely displaced, it involves ACL insertion only. Type 3B is completely displaced, it includes the entire intercondylar eminence. Type 4 was later added by Jerkins in 1977, that is combination of the entire fragment. The surgical technique we used was the standard anterolateral and anteromedial portal were made, diagnostic scopy was done, fracture crater was adequately cleaned and additional cancellous bone curated to achieve the better reduction. After that, the 2 drill holes were made by 2.7 mm guide wire, just anterolateral and anteromedial to the ACL avulsion and exiting on the medial tibial cortex. Through the medial portal, bite is taken through the ACL base, posterior half loop is passed in the accessory lateral portal, retrieved and fiber wire number 2 passed through this loop and exited in the medial portal. Both the end of fiber wire were held under traction and reduction is assessed. In full extension, roof impingement is checked and tied over endobutton in extension. These are the surgical techniques. These are the intraoperative images. Figure 1 is showing that this is a avulse fragment from the tibial eminence. Figure 2 is showing that avulse fragment being divided with a saver and crater is cleaned. Figure 3 is showing that drill holes are medial and lateral to the ACL. Figure 4 is a fiber wire is securing ACL close to the avulsion into the tibial tunnel, and the final step, fiber wire is tied over the endobutton. This is the post-op X-ray showing the nicely reduced ACL avulsion fracture from the tibial eminence. The post-operative management after the surgery, knee was placed in a knee brace, quadricep strengthening and straight leg raising was started without the weight bearing. From the 3rd week onwards, the partial weight bearing for another 3 weeks with hinge brace with gradual flexion was started. From 6th week onwards, the weight bearing as tolerated with hinge brace was started. From the 8th week, full weight bearing was started and patient was gradually returned to the activity. The results, out of total 18 patients, 7 patients were having the right knee and 11 patients were having the left knee, and out of 18 patients, according to radiological classification, 6 were coming in a type 2 according to Mayer's and Macabre, 9 were of type 3 and 3 were of type 4. Average time of surgery from date of trauma was 6 days. The patient was assessed at 2, 4, 8, 12 and 24 weeks. The IKDCA score was done in 16 patients at 6 months follow-up. The 2 scoring systems were used in our study was Lysol and IKDCA scoring. The Lysol scoring before the pre-op was poor and post-op the patient range in the 90 to 95 was 11, the percentage is 68, and the 85 to 90 the number of patients which coming was 5. Discussion: the displaced ACL tibial avulsion fracture need operative intervention to obtain reduction of the fragment into the crater. ACL retaining surgery has an advantage of proprioception and neuromuscular control with help of mechanoreceptors. The arthroscopic pull-out suture fixation technique is the preferred modality as it allows magnified vision, accurate reduction, minimal soft tissue dissection, stable fixation, management of associated intra-articular pathologies. Tibial avulsion of ACL fixation with arthroscopic pull-out suture fixation has good post-operative functional outcome in our study. So we recommend this technique for the treatment of this type of fracture. Conclusion: the arthroscopic pull-out suture fixation technique is an effective method for the fixation of ACL avulsion fracture with respect to knee stability, range of motion, and reduction of pre-injury activity level. These are my references. Thank you.
Thank you. This is the mention
No, sir, there was no any age limit.
Even children.
Yes, sir. Mostly the patient were coming in the adolescent age groups. We have operated a patient of 5 years, sir, but the patient was not in follow-up, not in continuous.
Your age group is 14 to 45 years age.
Yes.
This is your study.
Yes.
My question is, you select the suture fixation, pull-out suture with arthroscope, and your classification from 1 to 4th, where the combination is more. My question is, you just put all suture in the all cases, your study.
Yes, sir.
My question is, how much is it more effective as the other option of fixation, like putting a screw through the fracture part? So main part is a reduction. How can you assess reduction? Because reduction is not in your hand. Just you pass the suture from back of the ACL and pull through and tie it. So automatically where it goes, it's not in your control.
Yes.
So how can you control this thing?
So fracture crater was identified, sir. So fracture crater was identified, and after that, the post-operative, the X-ray was taken that shows that the fracture was reduced on the previous ACL avulsion fragment place.
Right. So first thing is to reduce the fragment.
Yes, sir.
And second thing is fixation. This is one aspect.
Yes.
Your aspect is you just pull around the suture through the
So reduction was
ACL or
assessed
back.
intraoperatively, sir, before the tie of the endo buttons.
Yes. So you fix it and then you assess by arthroscope.
Yes.
If you are finding that it is not accurately reduced, that is situation.
Yes, sir.
So what do you do in this such situation?
So we will try
Follow
to
my
again,
point. Follow my point.
We will try to again the reduce the fracture, avulsion fracture before fixing to the endo button.
So revise the procedure.
So intraoperatively only, sir. Not
You just can change the direction.
What is the direction of ACL fiber which is attached to the tibial spine, where you want to put the fracture part on?
Sir, on the native ACL avulsion, sir.
Anterior superior or posterior superior or medial, where?
Sir, I am not getting it, sir. Can you repeat, sir?
Fracture part of the tibial spine, you are pulling it. Where you want the fracture part to stay? At the fracture, where it has been fractured. So where it is exactly fractured in? Anterior superior, right? So you are pulling it and you are seeing also whether it has reduced or not, right?
Yes, sir.
And again you have to see the tension of the ACL as well.
Yes, sir. The bite.
Right. And in the same time you will see all the meniscus, PCL, whether it is injured or not. Suppose the laxity is there or there is a malreduction, what is the complication occurs to the patient?
Sir, it might lead to arthropybrosis, which will lead to next pains or stiffness.
Pain stiffness. Can the patient extend his knee fully?
Sir, loss of extension and arthropybrosis.
Arthropybrosis. Have you heard of non-union?
Yes, sir. It can lead to, if improper reduction is there, it can lead to
non-union as well. Right.
One condition where the bone fragment is comminuted. So it's very difficult to locate actual site of reduction. So at such situation, what are the assessment points? How can I assess my reduction is okay? Because fragment is comminuted, not fixed to the just a single one piece. So you just oppose the thing and tie this, or to look for the accurate reduction.
So we will try to get the reduction as much as possible according to posterior superior quadrant in the posterior superior direction.
Okay.
Your direction of the tibial tunnel will be where?
So it will be coming from the
In
middle.
comparison to the tibial tuberosity, you just tell me the real landmark.
Yes, sir, it will it should there will be two cheating point. One is the anterolateral and anteromedial to the native axial arousal pattern.
Question, how much distance from the plateau to lower one? Or the above the tibial tuberosity or just below the tibial tuberosity or whatever the thing?
So at the level
Where is the right side for the suture tie-up in the tibia?
So it should be at the level or the below of the tibial tuberosity.
Okay.
And medial or lateral?
Some middle side.
Medial side.
Are we using any guides or
These are axial tibial guides, sir. We are using at the 55-degree angle.
Dr. Neeraj, if it is one piece, if it is in one piece, you pull it out, it will stick in its plater itself. It will sit in its plater itself. There is no need of accurate reduction. This is non-articular portion.
Yes, sir, non-articular portion.
Non-articular.
Yes.
And if it is a comminuted one, even then pull-out technique is better than the screw pieces.
Yes, sir, because sir, it doesn't need implant removal.
Unite. It will not, if it is not delayed more than 3 weeks, it will unite. Thank you.
Thank you, sir.
Is there a study of open reduction and fixation versus arthroscopic repair? Is there any study? And if there is any study of open reduction and fixation with arthroscopic repair, and how the results vary?
Sir, can you repeat the question, sir?
I'm interested in open reduction of that fragment and fixation in comparison with arthroscopic repair.
So we have taken that as I have read that journal, sir, but the arthroscopic fixation is more superior to open, but sir, in the way of the accurate reduction, sir, and for open.
Thank you, Dr. Rajiv. He is speaking on comparative study of osteosynthesis of distal tibia intra-articular fractures using medial versus anterolateral plating. Good luck.
Good afternoon. Comparative study of osteosynthesis of distal tibia intra-articular fractures using medial versus anterolateral plating. It is a challenging task for orthopedic surgeons due to extensive comminution and lack of adequate vascularity. There are many methods to treat intra-articular distal tibia fracture, like conservative external fixation, medial lateral plate, and open reduction. Now, my objective of the study is to compare the outcome of osteosynthesis of distal tibia intra-articular fractures using medial versus anterolateral plating. This was a comparative study in which total 36 patients were taken for a study having distal tibia intra-articular fractures. 18 patients were treated using medial LCT, while another 18 patients were treated using anterolateral LCT from December 2019 to December 2021. The functional outcomes was measured by TEDI and Weiss clinical assessment criteria. My inclusion criteria is adult more than 18 years of age, both male and female sexes, closed and compound grade 1 fracture. Exclusion criteria: compound grade 2 and 3 fractures, fractures with neurovascular complications, chronic moribund conditions, pathological fractures, patient not willing to participate in the study. Now, after plating, the time taken in radiological union is compared in both medial and anterolateral plating. In medial plating, out of 18 patients, 2 patients, there was a complete radiological union after 40 to 15 weeks. In 8 patients, there was complete union in 16 to 17 weeks. And like this, 5 and 3 were still 18 and more than 20 weeks. In anterolateral plating, this was similar, almost radiological union was similar in both types of the plating in our study. Now, complications. In medial plating, out of 18 patients, 2 patients, there was infection post-operatively. There is 3 wound adhesions in 3 patients of medial plating, and 1 there was hardware prominence, and 1 was malalignment. In anterolateral plating,
There was one case of infection, there was no wound adhesions, and there was no hardware prominence, and there was one case of malalignment. Now functional outcome. In medial plating, there was one patient had excellent result, 2 had good result, and 12 patients had fair result, but 3 patients had poor result. This was assessed using the Kenny and Weiss criteria. In anteroplating, in anterolateral plating also, there was a fair result in more maximum percent, 61%. There was a fair result. Now result, in majority of cases, complete union was achieved by 16 to 20 weeks in both method of fixation. In both method, the patient started using full weight bearing in 16 to 20 weeks of time. But post-operative complications like infection, wound adhesions, and hardware prominence was like more in medial plating. And both method of fixation has fair functional outcome. This is some X-rays. Now conclusion. Based on our study, we conclude that for distal tibia interarticular fractures, anterolateral plating has fair functional outcome with less post-operative complications. Thank you. No sir, explosion criteria was compound fracture grade 2 and 3 and moribund patient sir, which is means survival is.
How you take the decision in diabetic patient?
Yes sir.
It's very common. That is very common. So how do you take a decision of treating this type of patient?
Sir, we prefer surgery after wrinkles and appears and with good antibiotic coverage with the diabetic control.
In all cases, you wait for
yes,
the
sir.
second, not only diabetic.
Yes.
That will take more than 3 months.
Yes, sir. We will wait for sir radiological union report.
All cortexes or 3 cortexes?
No, sir. 3 cortex.
Will suffice.
Yes, sir.
So intra-articular, would you like to go for CT?
Yes, sir.
So after CT, and then you will decide that anterolateral plating you have to do or the medial plating you have to do. What are your criteria for anterolateral plating?
Sir, in our study we have equally randomly divided the patient, sir, and we will see the outcomes of both.
So 50% cases you
yes,
do
sir.
with anterolateral plating and then medial plating.
Yes, sir.
So what was your outcome?
Sir, union was almost same in both cases, but the post-operative complications like infection, hardware prominence, wound adhesions was seen more in some medial plating.
Select medial or lateral plating. What do you feel more easier in respect of your operative skill or operative benefit, or in terms of complication post-operatively, medial one or lateral one?
Sir, surgically, sir, by doing medial plate is easy for doing, but to reduce, naturally reduce intraoperatively or the intra-articular component, it's better for anterolateral plating because we visualize the joint nicely, sir.
Which one you like most?
Sir, anterolateral, sir.
Is there I think the soft tissue conditions are better and tissue dissection is proper, you can go medial plating as well.
Yes, sir, but there is chances of
wound adhesions and other chances are there.
But very difficult to put plate on the lateral side, on the tibia, especially the lower side.
Yes, sir.
And where the combination of the lower part, it's very difficult to hold the fragment properly.
Yes, sir. There is some technical or surgical skill needed in anterolateral plating.
Any role of bone grafting?
So in first to go, I think not really.
Is there any relation in your decision making about the wellness department or marriage department? Suppose a patient is wellness department and intraarticular factor and patient is wellness coach. How you take it? How you take it? In wellness and wellness department.
Thank you, Dr. Rajiv. I would like to call upon Dr. Good luck, sir.
Good evening, everyone. I am Dr. Sushant Kishore, and I will be talking about a review of medial subtalar dislocation caused by. Coming to introduction, the subtalar dislocation is a rare injury characterized by simultaneous dislocation of distal articulation of talus at both talocalcaneum as well as talonavicular joints. It can occur in many directions, medial, lateral, and can produce significant deformity. Most common is medial dislocation. These injuries are often frequently associated with fractures, but isolated dislocations secondary to low energy trauma are also reported. Methodology, we report 5 cases of isolated medial subtalar dislocation, which was due to low energy trauma itself. After X-ray, prompt close reduction was performed with traction, counter-traction, plantar flexion followed by eversion. Post-reduction, X-ray and CT scan was done to look for alignment of post-reduction and to rule out any associated fractures. None of the cases has associated fractures. All patients were then managed conservatively by below knee cast and were asked for non-weight bearing walking for next 4 weeks. At 4 weeks, casts were removed and gradually all patients started full weight bearing walking at 6 weeks. Patients were followed up till 1 year and assessed by AOFS score. This is a case 1, shows the clinical picture and the pre-reduction X-ray of showing isolated medial subtalar dislocation. And here is the post-reduction. Similarly, this is again medial subtalar dislocation without any associated pathology. And this is the post-reduction X-ray with the slab given. Afterward, it was converted to cast. Sorry for the technical glitch. It was shown a video of how to perform reduction. And discussion, this case series confirms that the mechanism of injury is an important factor in predicting the final outcome. Subtalar dislocation secondary to high energy trauma are often associated with osteochondral fractures, which result in significant complication. Low energy trauma generally doesn't produce long-term morbidity. So prompt reduction is very important in order to minimize soft tissue and soft tissue injury and neurovascular complication. Although CT scan is recommended post-reduction to identify any occult fracture. Subtalar dislocation caused by low energy trauma, if adequately reduced in an emergency room with or without anesthesia, generally heals with conservative treatment, reducing the risk of significant complication. Thank you.
And plantar flexion. You reduced it by traction and plantar flexion.
Traction, contraction, plantar flexion, and medial eversion. Because my case where medial
medial subluxation is very common.
Yes, sir.
So commonly all 5 cases you got medial.
Yeah, my cases were all isolated subtalar medial subtalar dislocation without any associated pathology, and even caused by low energy trauma.
So when the talus is dislocated,
yes, sir,
what all ligaments you suspect that it has gone?
Because my cases were medial subtalar dislocation, I expected lateral talocalcaneum ligament to be sprained.
Talocalcaneum,
yes,
right?
And even this subtalar dislocation is also often associated with talonavicular dislocation.
So there could be a chance of medial talonavicular ligament strain.
Talonavicular ligament also has gone. You are your high degree of suspicion is
yes,
there.
Yes, but my cases were low energy trauma, not a high energy trauma. The literature doesn't suggest higher complication or ligament injury in these cases.
Yeah.
So I just went with the conservative management, followed up after 4 weeks, removed the cast, looked for the AOFS score at 4 weeks. If it is good, which all the patient had, I asked them to start full bed bearing walking, and all of them started full bed bearing walking at around 6 weeks. So I didn't go for MRI even during this phase.
So you didn't go for MRI for ligament injury?
No, sir. No, sir.
So what are the parameters you will look in the X-ray after reduction that you are happy with?
I did CT scan post reduction to look for any occult fracture. That also excluded any mal.
I am not asking fracture. I am asking you have reduced it. Now you have gone it for X-ray.
Yes, sir.
So when or in the IITV, what are the parameters you will see that you are happy that you have reduced it properly? There is no fracture in your cases. So what are joints you will see? My question is that.
Talocalcaneum joint.
Yeah.
And talonavicular joint.
Right. This is the lateral view you will see that.
Yes.
What do you give the message for this study?
Yes, sir.
What is your message to after this study?
When the medial subtalar dislocation is caused by low energy trauma, if adequately reduced in emergency room with or without sedation, it leads to better outcome without any complication which are often associated with high energy trauma.
Yeah, your study group is very low, only 5 patients. So we cannot say, we cannot conclude on this very low data.
Yes.
Okay.
Do you see the clear space? The clear space.
Clear space, that is mostly due to tibio-talar strain.
Medial malleolar center.
Medial malleolar.
Both should be equal.
Yes, both should be equal.
Is there any chance of syndesmosis disruption?
Literature doesn't give much this thing that there is a chance of that injury as well. But sometimes very few cases have calcaneofibular ligament injury as well as
in post-operative or pre-operative CT, you find any disruption of syndesmosis?
Any disruption of?
Syndesmosis.
No, sir. No, sir. No, sir.
Thank you, Dr. Sushant.
Thank you.
Now,
डॉक्टर भरत सर, सेक्रेटरी डॉक्टर महेश प्रसाद सर एवं आप सभी जितने भी उपस्थित हैं, मैं आप सबों को बहुत बहुत धन्यवाद देता हूं। और जो मेरे ऑर्गेनाइजिंग टीम है जिसने इस कार्यक्रम को सफल बनाया, इस ऊंचाई तक ले गया, मैं उस सबों को बहुत बहुत धन्यवाद देता हूं। और मैं चाहूँगा कि सभी लोग जिनका मैं नाम बोल रहा हूँ आए। डॉक्टर रोशन सिंह, डॉक्टर रोशन, डॉक्टर पंकज, डॉक्टर कुणाल, रोशन कहाँ पे है? डॉक्टर शमसूर होदा, डॉक्टर रोशन, अभी था नहीं था, डॉक्टर हरि प्रसाद सर, हरि प्रसाद सर क्या करें, नहीं कर रही तो इन लोगों को मोमेंटो लाओ तो सफलता मिली है, यही 4 पिलर हैं जिनको देख लीजिए, इसी के ताकत पर, इन्हीं के लोगों पर हम खड़ा होकर झंडा फहरा रहे हैं सफलता का। इसलिए इन तीनों प्यारे भाइयों को मेरे बहुत बहुत धन्यवाद। भरत सर
So now I will request our organizing team to felicitate our level organizing secretary Madhuसूदन sir. हम चारों ऑर्गेनाइजिंग टीम अब फेलिसिटेट करेंगे हमारे प्यारे फेवरेट डॉक्टर मधुसूदन सर को। सर आपने जो हिम्मत दी बिना से कुछ नहीं हो पाता सर। ठीक है सर मधुसूदन सर।
थैंक यू। वो इस कार्यक्रम के अंतिम दिवस पर आप लोगों को बहुत बहुत धन्यवाद देता हूँ, क्योंकि कार्यक्रम के सफलता के पीछे जितने भी डेलीगेट्स हैं, फैकल्टी हैं, हमारे बोआ का टीम है, सबों का बहुत सहयोग रहा। होटल मैनेजमेंट रहा, ISCS ग्लोबल रहा, हरी ऑडियो विजुअल रहा, इन सबों ने एक साथ एकत्रित होकर मुझे मदद किया। वरना हाजीपुर में इतना बड़ा कॉन्फ्रेंस करना और ये सफल बनाना, ये मेरे बस की बात है, किसी की बस की बात नहीं है। इट्स ए वेरी टफ जॉब। इसलिए मैं आप सबों को इस मंच से मैं सबों का चरण स्पर्श करता हूँ और सबों को प्रणाम करता हूँ और इस सफलता का श्रेय देता हूँ। थैंक्स टू ऑल ऑफ यू फॉर दिस ग्रैंड सक्सेस कॉन्फ्रेंस एंड आई रिक्वेस्ट सर सर आपसे टू से फ्यू वर्ड्स।
नमस्कार, गुड आफ्टरनून। मेरे टेन्योर की ये अंतिम शाम है। मैं बेहद भावुक और सेंटिमेंटल हूँ। इस पद ने मुझे बहुत कुछ सिखाया, बहुत कुछ एहसास कराया। मैं शुक्रगुजार हूँ अपने एसोसिएशन का, जिसने एक सीधे साधे डॉक्टर में एक लीडरशिप का गुण भरा। मैं शुक्रगुजार हूँ अपने सारे मेंबर्स का, जिन्होंने मुझे मोटिवेट किया। मैं शुक्रगुजार हूँ उस हर आदमी का जिसने हमारी सफलता में, मधुसूदन जी की सफलता में सहयोग किया। इसका निचोड़ कुछ मेरे पास है जो शायद जिंदगी भर हम सबों को काम आए, मुझे भी काफ़ी काम आएगा। लेकिन कुछ निचोड़ है जिसको मैंने अपने PPT के रूप में क्रमबद्ध किया है, शायद आपको पसंद आवे। पेशेंस एंड साइलेंस, virtues of the wise people. Patience and silence are two powerful energies. Patience makes you mentally strong and silence makes you emotionally strong. ये बहुत वैल्यूबल बात है। कल की जो बातें थी वो देखने के बाद कुछ रिपल्सन सी बातें होने लगी है। इसमें साइलेंस और पेशेंस की ज़्यादा जरूरत है। It's a power of silence. Silence is the language of God. What are benefits of silence? It improves our learning curve. It increases our productivity. And if you have more patience, you can achieve anything in your life. And meditation helps in this. Meditation, anything that takes away from stress is a meditation. And it brings you close to yourself. आप अपने को पहचानना सीख जाइएगा। अगर आप शांत स्वभाव के हैं, मेडिटेशन करते हैं, गंभीर हैं, तुरंत आप रिएक्शन किसी बात का नहीं देते हैं, तो आप अपने आप को पहचानना सीख जाइएगा और आपका डिसीजन मेकिंग इंप्रूव कर जाएगा और दिस विल लीड टू योर सक्सेस। व्हाट डू यू थिंक once someone asks, what do you think success is? Success is to love save the moon. We all have our own definition of success. Someone say wealth, someone say health, someone say relationship or freedom, fame, etc. And many times it is said that definition of success is related to every person and not universal. But have you ever wondered what success is in eyes of God? God is love and love is God. So the ultimate success is to love. Love too much, accept and take people as they are unconditionally, accept them unconditionally, whatever they may be. Love is not an action, and loving too much means having the same respect, same warmth, same feeling of God for every person in our life. Whether those people are family, friends, soul connections, rivals or acquaintances, always take care of how you make them feel. बहुत important बात है. Absence of hatred is love. However hard a person has become, every person has a heart that beats and feels the emotion. There is an infinite divine love within each one of us, and the day our behavior with it changes, it will gradually improve. Your personality will be positive, your thinking will be positive. I took the charge on 17/4/21. Worked so many things. Mulson is with me. We developed Index Journal. We organized more than 20 webinars on various online platforms. The list is long, so I will not. This was covered by electronic media as well as press media. And we decided future plans, and we succeeded in most of our plans, like professional indemnity scheme, tailor-made academic program, formation of various committee like membership drive, member directory committee, it's a very beautiful directory, fellowship committee, etc. We succeeded in most of our plans. And lastly, move in silence. Only speak when it is time to say checkmate. Thank you, thank you, thank you. है हम लोग की टीम बरसों से रही है. एक नाम और भी है पिंदर जी का. बहुत से खुशी के क्षण और बहुत से घूमने फिरने की बातें और बहुत से प्रॉब्लम्स को आपस में हम लोग शेयर करते रहे हैं. तो एक लगाव मधुसूदन से हमारा बहुत शुरू का रहा है और मुझे पूरा विश्वास था कि इनका परफॉर्मेंस जो होगा वो लाजवाब ही होना है, क्योंकि इनका पर्सनल टच है. हर मेंबर्स के बारे में इनको पता है, क्या स्थिति है, कौन बीमार है, कौन अच्छा है, किसको मदद करनी चाहिए. और इन्होंने डिस्ट्रिक्ट कोऑर्डिनेटर का एक फोरम क्रिएट किया जिसके चलते हम लोग कनेक्टेड रहते हैं, सारे लोग कनेक्टेड रहते हैं. तो अच्छा लगता है. सारे आप लोग फैमिली मेंबर्स हैं हमारे, और ये कर्तव्य बनता है बीओए के प्रेसिडेंट का, सेक्रेटरी का, कि अपने फैमिली मेंबर्स का केयर ले, उनका पता लगा हुए. बीच बीच में कहीं भी आप रैंडमली भी आप अगर बात करते हैं तो एक एहसास होता है कोई हमारे साथ है, कोई एसोसिएशन. मुझे कोविड हुआ था, मैं बताऊंगा आपको. ये डिक्लेयर लोगों ने कर दिया कि गए दरभंगा में तो कौन सा हो गया, फेसबुक पे आ गया, यूट्यूब पे सब पे आ गया. लेकिन एसोसिएशन के लोगों ने जितनी मदद की मुझे पारस हॉस्पिटल में, वो मेमोरेबल है. कभी वो कर्ज में नहीं चुका सकता, चाहे वो AK सिन्हा हो, चाहे उपाध्याय साहब हों, चाहे अन्य हमारे एसोसिएशन के मेंबर थे. सारा उनका आशीर्वाद था, उनका सहयोग था, जिसके चलते कि फर्स्ट पेज में मैं बच सका. मैं बेहद शुक्रगुजार हूँ. आप एसोसिएशन पे भरोसा करना सीखिए, कॉर्पोरेट कीजिए और कंडेम मत कीजिए. किसी दूसरे के सामने तो आलोचना ही मत कीजिए, अपने कलीग की आलोचना नहीं करनी है, क्योंकि अल्टीमेटली आपका कलीग ही आपके साथ खड़ा होगा. समाज खड़ा हो या ना, मैंने देखा है, मैं इतने नज़दीक मौत के था, मेरे पास ही मेहनत कर रही, मेरे बगल वाले बेड पे डेथ हुई, पहचान रहा था, मेरे बहुत अच्छे मित्र थे, मधेपुरा में साथ साथ हम लोग प्रैक्टिस करते थे। अब सोचिए कि एक आपका कलीग डेथ बेड पे डेड हो गया और आप उस नंबर में लगे हुए, आपकी क्या फीलिंग होती होगी? एसोसिएशन के लोगों ने कमाल किया, पूरा केयर मेरा लिया, मैं हाईली ऑब्लाइज हूँ अपने एसोसिएशन के मेंबर्स के। कब कौन ट्रैप में पड़ेगा आप नहीं जानते, आप भरोसा कीजिए हमारे एसोसिएशन में, कोऑपरेट कीजिए और कुछ पार्ट अपनी कमाई का लगेगा कुछ अजीब सा डोनेट करते हैं ना, कुछ रखिए, जब मौका मिले डोनेट कीजिए एसोसिएशन को, खड़ा कीजिए, मजबूत कीजिए, क्योंकि आपकी जो माने अर्निंग है और जो आप जमा करेंगे यहाँ, डोनेशन कहीं और मंदिर मस्जिद में मत कीजिए, आप एसोसिएशन को डोनेट कीजिए। ये सारा एसोसिएशन हम लोग को या हम लोग के बाद हमारे फैमिली मेम्बर्स की मदद करेगा। जितना धनी रहेगा हमारा एसोसिएशन उतना बेनिफिट हर मेंबर्स को। कभी कभार एक दो प्रॉब्लम होता है, उसमें मदद भी लेगी एसोसिएशन, अब भरोसा कीजिए। थैंक यू। मसन जी प्लीज। अच्छा, मैं एक मोमेंटो देना चाहूँगा मसन जी को उनके दी बेस्ट परफॉर्मेंस के लिए। First organizing secretary I ever seen, है ना? I ever seen. कोई नेगेटिव बात इनके पास नहीं है, सब कुछ अच्छा ही अच्छा है। थोड़ा बहुत 5% हो सकता है कुछ। थैंक यू।
थैंक यू सर। सर 2 साल जब मैं सेक्रेटरी था पिछले बार, तो सर प्रेसिडेंट थे और पिता समान मेरे साथ थे। मैं जो भी डिसीजन लेता था सर हमेशा कहते डन डन करो, एकदम करो जो डिसीजन ले रहे हो। सर आप मनोज चौधरी सर मेरे प्रेसिडेंट रहे, दोनों आदमी हमको बहुत शिक्षा दिए, बहुत ट्रेनिंग दिए। सर आप दोनों के इस मन से सर चरण स्पर्श करते हैं और बहुत बहुत धन्यवाद देते हैं।
Now this is the session of end of our conference, and I think this is the most important thing too. And now come to the award section. Our PG quiz, Professor R.P. Singh Gold Medal, Dr. R.R. Ganguly Memorial Gold Medal. Another Best Participation Award and Best Stall Award. So before going to give award to our PG, so today I am sitting the audience and watching the PG quiz. Our past secretary Dr. Rajiv Anand, Dr. Anup and Dr. Rajiv Raman will conducted this session, and I will surprise that the most of the participants from the different medical colleges they participate, but it is very unfortunate to I have to say that our Patna Medical College and IGIMS has no participation. So it is the most prime thing, and the way all our participants they participated in the function, they really had their own interest. So my appeal to all postgraduate students to participate in this PG quiz, so it will raise the standard of our association too. So thanks to all our PG to participate in such type of conference, and I will announce the winner of this gold medal PG quiz. And first prize goes to Patna AIMS. The 2-person team, Dr. Swam Prakash Das and Dr. Mohit Kumar Verma. And I will request our President Dr. S.N. Saraf sir to come and give the prize and memento, medal. Thank you. Yeah, Mohit Kumar Verma. Thank you, Swam Prakash and Mohit Kumar. Have a wonderful job. And our next second prize goes to Nalanda Medical College, Patna. And the name
Dr. Rahul Raj and Dr. Abhimanyu Kumar. Dr. Rahul Raj? Nowhere. And the third prize goes to Paras Hospital, Patna. Dr. Neeraj Raj and Dr. Puspendra Rathore. So give a big hand for him. After this PG quiz, NMCH, Rahul Raj and Abhimanyu Kumar. You are Rahul Raj. So please come and take your award from our President, Hassan Saraf sir. Raise your hand. Thank you Rahul Raj. Congratulations. And after PG quiz section, Nihal Singh, RP Singh gold medal. So I request our President Dr. S.N. Saraf sir to give a medal for this award. And congratulations Nihal. And next award is Dr. R.R. Ganguly award goes to Dr. Vishal Anand for the first best paper presentation in all respects. Congratulations Vishal. Please give a big hand for him. And now S.N. Saraf sir to hand over their collar to our new President Dr. Bharat Singh. So congratulations for new President Dr. Bharat Singh sir to take a charge on this auspicious occasion, and I am sure he will continue as a milestone history of BOA. And before going to take a speech from our new President, to call Dr. Madhusudan for giving a Best Participation Award and Best Stall Award to corresponding person.
Thank you, Secretary sir. The Best Stall Award goes to IPCA. IPCA people, Dr. Manoranjan, come with him. Sir, Dr. S.N. Saraf sir or Dr. Bharat sir? Or Dr. Mahesh sir, please give the prize to IPCA.
आइए
Best Participation Award, Omni Pharma.
in charge for BOA for further action. And I will request our new President Dr. Bharat Singh sir to come and say few words about our association.
Thank you, Maharaj. First of all, I thank my all BOA members who believe in me and elected me uncontested as a president of the Bharat. After getting elected president-elect, I conducted elections of the office bearers. I tried my best to elect all the persons office bearers without elections. But there are everywhere some nooks and corners are there. So one post was contested. And for that there are so many discussions occurred among our members on the BOA platform. Then we decided to do the e-voting for the secretary elections. We conducted very smoothly, no hue and cry among us, and we all behave like a brotherhood, and we elected our president, Mahesh, and after that I myself and Mahesh ji are doing work with so that our association will rise very fast. It means before myself and Mahesh, BOA is not rising, that is not my meaning, but we tried our best and we have planned something for the BOA. First of all, academic activities. You all know after taking charge, 4 or 5 CME and a small conference has been conducted successfully. And we tried that all conferences, even individual or of any small association, should come under the aegis of BOA. And we are achieving. Every person who is going to conduct any conference, they comes under the aegis of BOA. So academic activity has been planned, and most of you see in the platform for BOA, regularly Mahesh is putting new conferences or CME, so that will be known to you. Fellowship program is not regular in our association. So we plan this time because 2.5 years has been wasted in the COVID era. So we planned some fellowship program so that our members should go to another places, learn something and return and benefited the associations. Third thing is, as Dr. Saraf said, our association should be rich. There should be no dearth of money. We received association with 25,000 money in the account. So I feel very sad that our association and everybody is a good practitioner, or our association is so poor. So we are going to do something new for fundraising program. I requested all my members, those who are contact of any person who want to donate some money for something, he will donate the money to BOA accounts. Second thing, those who are conducting conferences, they should pay some amount to the BOA conferences, so that some amount will be increased. Last thing, we have decided, or it is a norms, 10% of total collection of the conference should go to the BOA account, and rest money after expense, whatever amount, 1 rupee to 1 lakh or 10 lakhs, rest amount should be deposited in the BOA account. Yesterday in the GOV meeting or in executive meeting, we passed that all money, rest money should go to the BOA account. And almost it is passed, so further any conferences money will be go to the BOA. Third thing, new lessons. We are going to start new lesson at Bhagalpur. Name will be disclosed later on. but new elections will be started at Boacon. On elections point, always there is something, this thing is wrong, this thing is right. So we want any elections on e-elections. This time we conducted election e-voting, and in future all elections of the BA officers should be conducted by the e-voting. And decision of the venue should also be decided by the electronic voting. Each and every person will be indulged and he will vote for the further venue of the conference. Last thing, membership drive. I thought every person should be member of BOA. Whoever passed or not passed. Even PG students should be made as a associate members. And not only BOA, also for IOA. If you are not a member of the IOA, you will never demand for the conference in Bihar. संगठन में शक्ति होती है, तो संगठन जितना मजबूत करेंगे, अपनी क्षमता जितनी बढ़ाएंगे, दूसरा स्टेट आपका कॉन्फ्रेंस बिहार में 92 में हुआ था ना, IOA कॉन्फ्रेंस, उसके बाद आज तक नहीं हुआ। हम लोग हमेशा हार जाते हैं वोटिंग में कि मेरा वहाँ संख्या है। 2002 में 20 साल हो गए, दोबारा हम लोग क्यों नहीं? So you became a member of IOA and BOA both. Membership drives, and our target is you will make each and every person's member of BOA and IOA. Thank you.
President Dr. Bharat Singh sir, and one thing I would like to say about the postgraduate student, about the associate member of IOA. I discussed with our IOA secretary Dr. Naveen Thakkar yesterday night, and he told me that all postgraduate belongs to any medical college of government or non-government medical colleges in our Bihar. They make a list of the postgraduate, and under which he postgraduated. That means the name of the guide. You just make a list, send to me, means a BOA office, my personal WhatsApp number, so that I can give him to a complete list of Bihar for associate member, so he can further give a notice to our association to make all at once with your recommendation. So I would like to request all postgraduate students to make your associate member for IOA and as well as our BOA also. What is the importance of that? If you make an associate member, automatically after completion of your degree, you will be a member of that association. And secondly, you just participated actively in our association. And if our number is increased, we have enough power to give and hold some more and more fellowship to our state. So number is the most important thing. So again I appeal to all of you to make a number increase in our association as well as IOA. And before going to end of the session, I call Dr. Madhusudan for a photo session of the whole faculty, our President, Secretary Dr. Rajiv Anand, our President Dr. Manoj Chaudhary sir, Dr. Organizing Chairman Dr. Hari Prasad, to come forward to come and make a photo for this session.
सबसे पहले I request all my members of the organizing committee और member please come, और हम लोग हरी सर से रिक्वेस्ट करेंगे जिनके नेतृत्व में हम लोगों ने काम किया है, वो हमारे चेयरमैन और वाइस चेयरमैन रहे, हमेशा हम लोग को गाइडलाइन देते रहे, और अभी सर को हम लोग सब लोग सम्मानित करें। सर प्लीज आ जाइए सर।